We are live, ma'am. Please start.
Good evening, everyone. I would like to welcome you all on today's webinar on Oncology Conclave 2024. It's my pleasure to invite Dr. Akesh Taran, sir. Sir is consultant medical oncologist, director, Taran Onco Care Indore. For the welcome and introductory note, the stage is all yours, sir. Over to you, Taran, sir.
Thank you, Abhimanyu. Uh, I am delighted to invite you all for being a part of this webinar on 14th and 15th of November in the name of Oncology Conclave 2024. And I am thankful to all the dignitaries and faculties to be taking part actively in this conference or webinar. And let us start with Dr. Jay Mehta, sir. I feel he is the most renowned pathologist and he's undoubtedly the best person in country for the histopathology part. So may I request Dr. Jay Mehta, sir, to take proceed.
Thank you, Dr. Dharan, for that very kind introduction. I'll start sharing my screen so that. Okay, is my screen visible and I'm audible?
Yes, sir. Please continue.
Okay, so yeah, thank you for having me do the opening batter here for the webinar. So the brief for me to talk on advances in molecular profiling in non-small cell lung cancers. And I'm going to talk a little bit on uncommon EGFR mutations. Everybody knows about the common L858R and the EGFR exon 19 deletions. So let's talk about what are the atypical ones. The ones which are not exon 19 and L858R are atypical mutations. Typically, it's the exon 20 insertion mutation that you get. It's about accounting for about 5 to 10% of all EGFR mutations. Some of the other ones are also this G719X, L861X, and S768X. These are all collectively adding up to another 10%. They're all sensitive to afatinib. How do these atypical mutations differ? They have receptor activation mechanism, which is rather similar to the exon 19 deletions, but they have extra amino acids which are physically restricting the drug binding pocket. Therefore, the bulkier EGFR TKIs do not bind correctly to these receptors. Other option to use for exon 20 insertion mutations is EGFR MET bispecific antibody, amivantamab. That's one of the options. Quick thing here, when you read a NGS report with an exon 20 insertion, and if it's done on a kind of a real-time PCR, that's not the correct way to do it because you need to check what residues are involved. If the insertion is before residue 764, then it would still be kind of sensitive to the first generation EGFR inhibitors. And here's the picture which shows you that this is the residue 764 below the red arrow. And these account for about 6% of all the 10% or so of the EGFR mutation, exon 20 insertions. So it's very vitally important for you to understand whether the residue is, the insertion is before residue 764 or after that. So here's one IGV, and it's circled in blue here. The coding amino acid is 767, which means it's post 764 and will require something like a amivantamab. What about the EML4 ALK variants? Is it important to understand the variants? I would think so, yes. Variant 1, for example, confers higher sensitivity to ALK TKIs. Variant 3, on an average, worsens the patient's prognosis and predicts resistance to all ALK TKIs and increases the metastatic risk. So it's important to understand which variant, even if you get the EML4 ALK fusion. The shorter variants, B3 and B5, I have a higher proportion of metastatic disease versus the longer variants, variants 1 and 2. So in the report, we do mention when we have an ALK gene rearrangement, we make it a point to kind of identify which variant. In this case, it's variant 1, which is actually a good prognosis. What about KRAS? Because of G12C and G12D, which have monoclonal antibodies, it's important to identify KRAS even in lung tumors. KRAS mutations otherwise work better as a negative predictor of response to EGFR TKIs, and EGFR mutations do as a positive predictive factor. So it's important to understand that KRAS also needs to be looked at in lung tumors. What about BRAF? We also get BRAF mutations in lung tumors. It could be V600E or non-V600E. Interestingly, the V600E mutations tend to happen in females who are non-smokers versus the non-V600E, which happens in males who are actually current smokers. Now, it's also important to know which mutation in BRAF is. If it is non-V600E, then the standard drugs that you use for these tumors which are BRAF mutated, like dabrafenib and trametinib, do not actually work for variants or class 2 and class 3 BRAF mutation. So that's important to the medical oncologist to understand in the NGS report. In this case, this was a canonical V600E, but you see this, there's a whole table which tells you whether it's class 1, class 2, or class 3 BRAF mutations. What about the MET exon 14 splice site mutations and amplifications? All of us know that they are more common in females, elderly, non-smokers, and particularly with a sarcomatoid histology, and they portend poor prognosis for the patients. But these splice site mutations, which are typically seen in about 2 to 4% of the cases, tend to have coexisting MET amplification also in about 1/3 of the cases. Overall, MET amplification itself is found in about 1 to 5%, but a significantly more number, almost double or 3 times the number, when you have acquired resistance to EGFR tyrosine kinase inhibitors. The thing as a medical oncologist to look out in the MET amplified tumors in the NGS report is a gene copy number. If the gene copy number is more than 10, that's what is important for you to understand, because in this NEGM study, they said limited efficacy was registered in patients with a gene copy number less than 10. Whereas if you had a gene copy number more than 10, an objective response was registered in about 29% of pre-treated and about 40% of treatment-naive patients. So if you do get a MET amplification, please look out for the gene copy numbers. You can use either an RNA or a DNA-based method. RNA is definitely better than DNA-based method. The DNA method would have to have primer sets which target the intronic regions, including the splice acceptor, the donor, the branching site. So it becomes a little bit more complicated. So ideally, an RNA kind of RNA based method is the preferred choice. What about RET fusion? So important to understand in the NGS report, for example, here is which is the partner. The canonical partner is the KIF5B, but if you do get the CCB6, that is a second option, and that's actually better prognosis for the patient vis-a-vis the KIF5B fusion. Otherwise, nothing significant in the RET fusions. Again, you can use either of the DNA or the RNA-based NGS, but RNA NGS kind of outperforms the DNA to detect a RET fusion. Now, what about the HER2 new expression in lung tumors? So it's not the same as for breast tumors. What you tend to get is exon 20 insertion mutations in the kinase domain. Along with that, a very hotspot mutation in S310F or Y in the extracellular domain. There are a few other hotspots also in the extracellular domain. So therefore, you cannot use IHC or FISH. You have to exercise the option of using NGS for HER2 mutations. So HER2 mutations, amplifications are associated with the female gender, Asian ethnicity, non-smoking status, as well as moderate to poorly differentiated adenocarcinoma histology. Half of these patients who are HER2 mutant lung cancers, they tend to have CNS involvement. And they have worse survival outcomes compared to other patients with lung adenocarcinomas with oncogenic drivers. So as I said, unlike in breast and gastric cancers, doing IHC doesn't really help. You need to do NGS to identify if the mutation is in the extracellular domain, in which case you can use monoclonal antibodies or the antibody drug conjugates, such as the new ones which are available currently. And mutations in the kinase domain give you the preference to use the pan-HER2 tyrosine kinase inhibitors, such as afatinib. Now, not only the HER2 mutation variants, but if you identify the co-mutations, that's very important, because, for example, if you have a TP53 co-mutation, this leads to kind of additional resistance to anti-HER2 treatments in non-small cell lung cancers. So does the PI3K, AKT, mTOR pathway inhibition mutations. But this is a kind of a graphic which tells you if it's in the extracellular domain, you tend to get all these hotspot mutations, and so very rarely you can get these amplifications also here. And these are kind of targetable by monoclonal antibodies and antibody drug conjugates, such as trastuzumab deruxtecan. If it's in the kinase domain, or if it's an exon 20 insertion mutation, the choice to exercise these various PKIs that you have at hand. This is a IG view of this is an NGS report of a HER2 mutation, and you see this exon 20 insertion. In this case, it was a 3 base pair insertion. And here's a hotspot in the extracellular domain S310F. So it's important to know what kind of a HER2 mutation. Is it in the extracellular domain, intracellular domain, because your treatment options will vary accordingly. So NGS should be preferred, and when it's done, you should be able to recognize what kind of a mutation is there in the report. What about the NREG1 fusions? Now, typically associated with mucinous adenocarcinomas, a large proportion of mucinous adenocarcinomas of lung have KRAS mutations. The few which are not, some of them will have the NREG1 fusions, and they are kind of treated with afatinib. So here's a lung cancer with mucinous histology, and we have discovered it had an NREG1 fusion. NTRK fusions, exceedingly uncommon across the tumor spectrum. Everybody wants to use it, but they are very rare. They seemingly are associated with a higher level of TMB and PDL1. But remember that this a lot of times coexist with STK11 mutations. And the danger to this is that although you have a high PDL1 and a TMB, if you have the STK11 mutations, they kind of are associated with decreased efficacy to immune checkpoint inhibitors. So NTRK itself is not enough. One is if you do get an NTRK fusion, you're supposed to check it by IHC if the protein is being made. Secondly, look out for co-mutations also. NTRK fusions can also develop as a potential mechanism of acquired resistance to TKI pre-treated patients. So that's one of the other times you can actually get an NTRK fusion. Larotrectinib and entrectinib are potent and highly selective pan-NTRK inhibitors in clinical use. Secondary resistance mutations. So what we all know is the mutation in the ATP binding pocket, which is in exon 20, T790M. What about the other mutations? You can get bypass mechanisms such as MET amplification, HER2 amplification, and TRK I just mentioned. So these are the possible other ways that you can bypass the TKIs which are in action. Histologically, you can have a small cell transformation. So it's important to actually biopsy and not just obtain a liquid biopsy at the time of relapse if it's doable. And there's something called a tertiary resistance. If you give osimertinib, which is a T790M mutation-specific inhibitor, a very specific mutation called C797S develops as an acquired resistance to osimertinib. Even upregulation of NREG1 has been described as a potential mechanism of resistance to ALK inhibitors. This is concept of cis and trans when you're looking for resistance mutations. So clinical efficacy with a combination of first and third generation EGFR TKIs has been reported when the T790M and its mutant, the resistance mutation C797S, are in trans conformation, which means they are on different alleles. If they are on the same allele, it's called a cis conformation, in which case the efficacy is significantly lesser. So therefore, the knowledge of whether the C797S mutation is in cis or trans conformation is very important following osimertinib therapy to guide your subsequent treatment. And here's one of our reports which actually mentions that this patient, the C797S T790M conformation is in cis form, which means it's not going to be helpful to do that routine treatment. So this is my last slide, and various things, advances are always happening. You have on the left side the common mutations, and in the middle thing are emerging molecular biomarkers, BRCA, for example, FGFR fusions, HER2, HER3, PIK3CA, and NREG1 I already mentioned, but KEAP1, STK11, Notch, MTAP, they're all being investigated in lung tumors. And on the extreme right is the exploratory and potential molecular biomarkers such as RB1, NRAS, HRAS. These are all potentially targetable. So it's an evolving world. Maybe the next talk that one has, there'll be more things to be talked about, advances in lung tumor molecular pathology. On that note, thank you very much for hearing me.
Thank you, Jay bhai. And last slide was really very encouraging from patient point of view, because all the newer modalities which are coming and how to handle all the things. So once again, thankful as always. It's wonderful to have you. And
my pleasure. Thank you so much.
Thank you, Jay bhai. Now may I invite Dr. Shyam Agrawal sir. Dr. Shyam Agrawal sir is eminent or the first medical oncologist of Central India, and my respected senior. May I invite him for the next talk?
Yeah. Thank you very much, Dr. Rakesh. Good evening, everyone. Thanks to the Cancer Research and Statistics Foundation and AstraZeneca for providing me this very opportunity to have a discussion on reinventing the EGFR mutation adjuvant therapy. Can I have the first slide, please? Abhimanyu ji? Yeah. You have to operate the slides. Okay, thank you very much. Am I audible and visible? Am I audible?
Yes, sir.
Okay, so this is what the topic, reinventing the adjuvant therapy in EGFR mutated NSCLC. If we see the survival outcome in resectable non-small cell lung cancer, it is very, very dismal if alone surgery was done. If we see the stage 1B patient, 65 to 70% have 5-year overall survival. Stage 2, 50 to 70%. And further down, if it is patient has gone into stage 3 and operated, it is 30 to 45%. So as we all know that NSCLC represent approximately 80% of the so there are 80% of all, only 30% of patients can present with the resectable disease, and we have seen the survival outcome in a stage-wise manner. Next, please. So, what are the testing one should do if a patient comes to the early lung cancer? That is non-metastatic resectable lung cancer. We do only two kind of testing. One is EGFR, another one is PDL1. So there may be three combinations. Either both are positive, or both are negative, or you may have PDL1 positive alone. So we follow the approved recommendations for the treatment as per the outcome of the testing. Next, please. So this is what this study showed the prevalence of EGFR mutation in patients with resected stage 1 to 3 non-squamous lung cancer from the early cancer stage 1A to 3B. It has been conducted between the March 21 to October. Sorry for the disruptions. I don't see my slides. Can you put on this? I can't see my slides. Abhimanyu ji?
Yes, sir. Hello. Summer, am I audible? And my slides are visible?
Yes, it is visible.
अभिमन्यु जी स्लाइड्स नहीं दिख रहे हैं मेरे को.
सर मे बी आपका नेटवर्क इशू है, आप एक बार अगेन ज्वाइन कर लीजिए एग्जिट करके.
Can I talk to Mr. Abhimanyu? What is happening wrong with the slides? What's wrong with this slides? Do I have to reconnect?
Sir, just log out and log in again.
हेलो हेलो
हेलो।
तरुण भाई, क्या प्रॉब्लम है? हेलो।
सर मे बी सर का नेटवर्क इशू हो रहा है थोड़ा।
तो अभी मैंने कॉल कर लीजिए सर को।
मैंने अभी किया था जस्ट मैम।
He can re-log in. Hmm. Support team, can you help? Hello?
Yes, ma'am.
क्या प्रॉब्लम आ रही है सब टेक्निकल टीम?
मैम शाम सर फोन से ज्वाइन कर रहे हैं अभी।
अच्छा, ठीक।
मैम, उनका इंटरनेट कनेक्शन अनस्टेबल है, उसके लिए उनको दिखाई नहीं दे रहा था।
ओके ओके।
तारन सर, गुड इवनिंग।
गुड इवनिंग विकास भाई, क्या हाल चाल?
बस बढ़िया सर।
आई एम सॉरी।
नेक्स्ट वाले को ले लेंगे सर? मान लो इसको समय लग रहा है आपको।
Yes, I am ready if takes time.
आई थिंक दैट इज अ बेटर ऑप्शन अगर टाइम लग रहा है तो।
Yes, sir.
जैसा आप बोले सर।
अभिमन्यु।
श्योर सर, हम कर सकते हैं सर का टॉक। तब तक मैं श्याम सर को फोन कर लेता हूँ।
श्याम सर को फोन कर दीजिए आप,
डन सर।
ज्यादा आसान हो जाएगा अपन सबके लिए।
जी जी सर।
सो may I now invite Dr. Rajesh Patidar, sir. Dr. Rajesh Patidar is a well-known medical oncologist of Indore. May I request him for the next session over reinvent over perioperative immunotherapy and new frontier in early resectable NSCLC.
Thank you, sir. Please allow me to share slides from my end.
It's allowed, sir. You can
Yeah.
share it.
Yeah, slides are visible now.
Yes, sir.
Yeah. Thank you, Taran sir, for giving me this opportunity to speak upon a perioperative immunotherapy in non-small cell lung cancers. So if we see the all lung cancers, around more than 2 million new cases are diagnosed annually worldwide. And among them, around 85% of the patients are non-small cell lung cancer. But only 30% of these cases are actually resectable. These are stage 1 to stage 3, early stage 3. So in early stage 1B, the chance of survival or chance of recurrence, in fact, the 45% chance of recurrence or death are there. And in stage 2, there is 62% chance of recurrence or death. And in stage 3, there is 76% chance of recurrence or death is there. And we know that surgery is the curative intent option for non-small cell lung cancer apart from CTRT. But whenever feasible, we go ahead with surgery and the data with surgery is better. So as we know that there is still an unmet need because around 50% of the patient, even in early stage lung cancer after surgery recurs and dies. So there is still an unmet need. For 3 to 4 decades, the only standard of care was adjuvant chemotherapy in high-risk patient, that is cisplatin-based chemotherapy. Initially, based on ARITA meta-analysis, we used to give vinorelbine cisplatin or paclitaxel cisplatin. But now, if patient is having adenocarcinoma, pemetrexed cisplatin can also be given. But since long it was the chemotherapy was only the standard of care in adjuvant setting. Then the role of neoadjuvant immunotherapy was evaluated in the various trial, and the hypothesis for that was that there is a potential for more robust and durable anti-tumor response with immunotherapy, especially they can control micrometastasis better as we see in stage 4 cancer. There is a potential to prevent immune tolerance and escape mechanism that occur in early stage. Combining neoadjuvant immunotherapy and chemotherapy, further adjuvant immunotherapy is expected to improve activity and long-term clinical outcomes in stage 2 and stage 3 non-small cell lung cancers. And in adjuvant setting, hypothesis is that it has an acceptable safety profile and it can demonstrate potential to restore anti-tumor activity in non-small cell lung cancer when we use chemotherapy along with immunotherapy. There were various studies which have been done in this setting, in neoadjuvant setting or an adjuvant setting, and most of the immunotherapies has given many of these has given improved event-free survival. In Checkmate 816, chemotherapy with nivolumab in neoadjuvant setting improved EFS. In IMpower 10, it was atezolizumab which improved DFS in adjuvant setting. In Keynote 091, it is pembrolizumab in adjuvant setting which improved DFS. In ASEAN trial, perioperative chemo plus durvalumab improved EFS. In NEO-TORCH study, chemo plus toripalimab improved EFS. And in Keynote 671, it is chemo with pembrolizumab which improved event-free survivals. So there are various studies in neoadjuvant setting also and in adjuvant setting also. So in Checkmate 816, nivolumab plus chemotherapy was given for 3 cycles, then surgery was performed. And in another adjuvant immunotherapy trial, IMpower 10, chemo with atezolizumab was given for 1 year in PDL1 more than 1% patients. And in another trial, Keynote 091, it was pembrolizumab which was given for 1 year. So there are various studies of immunotherapy, which many of them are given in a perioperative neoadjuvant setting. Some of them were given in adjuvant setting, and some chemotherapies along with immunotherapies are given in a perioperative setting. So today the drug of interest is durvalumab. We'll be discussing the ASEAN, a phase 3 global randomized phase 3 trial. In this trial, the inclusion criteria was treatment naive patient with good performance status with resectable non-small cell lung cancer, that is stage 2A and 3B, based on AGCC 8, and in where lobectomy or sleeve resection or bilobectomy as planned surgery was planned, and PDL1 status was checked, and there were no documented EGFR or ALK alterations. In one arm, they gave durvalumab along with platinum-based chemotherapy for 4 cycles, 3 weekly, followed by durvalumab for 12 cycles. And in an experimental arm, they gave placebo with chemotherapy, followed by surgery, and then placebo for 12 cycles. If you look the baseline characteristics and plan treatment, the baseline characteristics in both the groups were quite well matched. In plant neoadjuvant platinum agent, we see the cisplatin was given in 27% of the patient, and around 70% of the patients received carboplatin. So most of the patients received carboplatin as a chemotherapy backbone. If you look for the result, in event-free survival at 36 months, that is at 3 years, in chemotherapy, in durvalumab arm, the event-free survival, probability of event-free survival is 60% compared to around 40%. And it was hazard ratio was 0.69, which was statistically significant. If we look for the event-free survival in all subgroup, in most of the subgroup, there was benefit of perioperative durvalumab, and whether patients were having PDL1 expression less than 1%, 1 to 49%, or more than 50%. So in all subgroup, there was benefit of perioperative immunotherapy. There was a clear and consistent EFS benefit which was observed regardless of planned platinum agent. So the benefit was there in both cisplatinum group and carboplatinum group. If you look for the PCR rate, that is pathologically complete response, the PCR rate was seen in 17% in durvalumab arm compared to 4%, which was almost quadrupled. And MPR, major pathological response, which was defined as the residual disease left less than 10%, which was seen in 33% in durvalumab arm compared to only 12% in experimental arm. If you see the PCR rate based on subgroup analysis, patient subgroups, PCR was in all subgroup, the benefit was there in durvalumab arm compared to the experiment, compared to the placebo arm. If we see the side effect summary, we know that these immunotherapies are quite well tolerated drug, like any other drug. Only side effects of concerns, what we see is immune mediated adverse events, and in durvalumab arm, grade 3, grade 4 adverse events were seen in 4% of the patients compared to 2.5% in the placebo arm, and pneumonitis of any grade was seen in around 4% in durvalumab arm compared to only 2% in placebo arm. And again, if we further see the different side effects, grade 3, grade 4 anemia was seen in 6% in the both arm. Maybe the contributory factor was chemotherapy. And neutropenia was again seen in 9 to 10%, grade 3, grade 4 in both the arms. So side effects were quite similar in both the arms. If you see the immune mediated adverse event, total around 25% of the patient had any immune mediated adverse event. Among them, only 4% had grade 3 and grade 4 adverse event in durvalumab arm. The common immune mediated adverse events were hypothyroidism, which all were grade 1, grade 2, dermatitis, pneumonitis. Hepatic events were seen in 3.2% of the patient. Among them, 2% patient had grade 3, grade 4 hepatic events. Hyperthyroid event was seen in around 2% of the patients. So we should, like any other immunotherapy, we have to monitor for autoimmune adverse events with durvalumab also. We know that stage 3 encompasses a different group of the patient. Stage 3 is from age N0, N1, N2, and N3. And from T1 to T4, anything can be stage 4. And if we look for the UK audit data from 2017 on treatment for stage 3 non-small cell lung cancer, less than 22% of the patient with stage 3A and less than 5% of the stage 2B received surgery as a part of their treatment. We know that up to N2 we can take patient for surgery, and N2 bulky patients we don't take for surgery. Otherwise, N2 non-bulky disease we take patients for surgeries. So neoadjuvant perioperative versus adjuvant immunotherapy have certain pros and cons. And if you look for the pros for neoadjuvant perioperative therapies, that there is a high efficacy due to the presence of tumor antigen and lymph nodes for the priming immune cells. And it has a better drug delivery due to preserved blood vessels, a smaller tumor facilitated complete with safety, and we can predict the prognosis by PCR, which is one of the prognostic indicator in many cancer. But if you see the pros of adjuvant immunotherapy, it is like treatment plan after accurate staging and biomarker testing, and there is no delay for surgery, which is a definitive treatment. But if you look for the cons for neoadjuvant therapy, around 15 to 20% of patients cancel surgery. If upfront we tell them for surgery, maybe most of them will undergo surgery, but there is a cancellation of surgery in 15 to 20% of the patients, maybe because of they might have, some of them would have good response. And if you look for the cons for adjuvant therapy, 30% of the patients after surgery never reach adjuvant immunotherapy treatment despite the proper counseling. So for patient with stage 3A, induction therapy followed by surgery may be offered if all the following conditions are met, like a complete resection of the primary tumor and involved lymph node is deemed possible. N3 lymph nodes are deemed to be not involved by multidisciplinary consensus, and perioperative mortality is expected to be low. So as we have discussed that both neoadjuvant and adjuvant immunotherapy is a standard of care, but especially stage 3 patients where many of the patients do not undergo surgery, in this particular patient, we should push for neoadjuvant immunotherapy, and later after chemotherapy and immunotherapy, we can consider them for surgery and then adjuvant immunotherapy. So if you look for the NCCN guidelines, NCCN guideline also recommend durvalumab along with doublet chemotherapy as a neoadjuvant setting in EGFR ALK-ROS negative tumors, in where we are planning for surgery. So to conclude, perioperative immunotherapy is a promising approach for early stage lung cancer patient. It has a potential to improve outcomes and reduce the risk of recurrence. The benefit of perioperative approach over neoadjuvant only approach is yet to be confirmed, but both are the standard, both can be considered as a standard of care. And this perioperative approach, in my opinion, it should be considered at least in stage 3 patients. Thank you. Thank you, team.
Thank you, Dr. Rajesh Patidar, sir, for a newer insights, which is, I think, a newer exploration of the world in the form of early lung cancer. This is going to change the scenario, and I hope we all are trying to incorporate these newer practices in our day-to-day routine clinical judgments. So, Abhimanyu, next talk is by Dr. Shaunak, or it's by Dr. Bharat, or
So it's by Dr. Shyam Agarwal, sir.
Okay, it's by. So, may I, or you're going to request Dr. Shyam Agarwal, sir? Has he joined?
Yeah, I'm there.
I'm sorry, sir, as you're not
I'm
visible.
really
Sorry,
Yeah.
and welcome back again to restart the talk. And please.
No, I'm really sorry for the network issue, but I will try to finish it off fast. So here we were like, we have our study where surgically resected stage pathologically 1A to 3B non-squamous NSCLC between March 21 to 22 33 centers across Middle East, Asia, Africa, and Latin America. They have found almost 50% EGFR mutated and EGFR wild type issues. And out of that, if we see the mutated ones, 50.5% were 19 deletion and 36% were L858R, and very low percentage of 790M. So, with this background, next please, we have another observation that more than two-thirds of the patients underwent only surgical resection. This blue line is only for surgical resections, and the yellow and orange is for the combination of radiotherapy or some kind of chemotherapy along with the surgery. So, but if we see the percentage of these patients in stage 2 and 3, only 46% patients received adjuvant therapy. Next, please. So, after initial treatment, more than 50% or the around 50% of the patient, they recur within 5 years if they undergone surgery, radiotherapy, and all chemotherapy. Their recurrence rate is very high. Next, please. And this is what the adjuvant chemotherapy, the form of cisplatin, was given by the ANITA trial. The observation versus chemotherapy, only there was 5% betterment after the 5 years. So not very significant in DFS or OS. Next, please. Next. And these are all different trials of using TKIs. 3 trials used erlotinib, 2 used gefitinib, and there has been a meta-analysis also what was the outcome of these adjuvant EGFR mutated patients by using the first generation EGFR TKIs. Next, please. So this is what the meta-analysis of 6 randomized trials, and which they say that there was some improvement in DFS, but there was no OS benefit. Next, please. So why these data have not resulted in a change to clinical practice? One is trials to date have been limited by the design or the size and other factors. There was no OS benefit demonstrated till date. Number 3, unclear if adjuvant EGFR TKI therapy resulted in cure or delay the recurrence, and there was no definite evidence on appropriate sequencing, which one comes first or next. Next, please. So duration of treatment was also not. And here is the big boss, the ADERA trial. And the study design was very simple. Patient with completely resected stage 1B, 2, and 3A NSCLC with or without adjuvant chemotherapy. The inclusion criteria was more than 18 years. Japan and Taiwan, they have more than 20 years. WHO performance status was 0 to 1. And there was confirmed primary non-squamous cell lung cancer with exon 19 deletion or L858R. And the brain imaging was also done, and it was resected if not preoperatively. Then the maximum interval between the surgery and the randomization was if patient has received adjuvant chemotherapy, that was 10 weeks, 26 weeks, and those who did not receive adjuvant chemotherapy was around 10 weeks. And then after the stratification, the 3 things need to be differentiated: stage 1B versus 2 versus 3A, EGFR mutation, which kind of mutation, whether exon 19 deletion or L858R, or whether they were Asian or non-Asian. And then the randomization received, one arm received osimertinib 80 milligram once daily, and another was the placebo. So the planned treatment duration was around 3 years. Treatment continue until disease recurrence, treatment completion, or discontinuation criteria met. Follow-up was also regularly seen in a different timeline manner. And points were primary endpoint were DFS by investigator assessment in stage 2 and 3A patients. And key secondary point were DFS in overall population, stage 1B to 3A, and the landmark DFS rate, OS, safety, health-related quality of life issues. Next, please. This was the study design. and see the significant separation of the curves. There was significantly improved DFS was demonstrated in primary as well as overall population. The stage 2 to 3A patients have hazard ratio was very significantly high. That was 0.03, 0.23, and then overall population there were 0.27. So the significant risk reduction and the death was found in the overall DFS. Next, please. And there were patients with CNS mets because adjuvant azumartinib has significantly improved CNS DFS. CNS matters a poor prognostic. We all know that is very, very poor prognosis among patients with an SCLC and associated deterioration in quality of life also. There is observation of improved CNS efficacy with osimertinib treatment because osimertinib has shown greater penetration to the blood-brain barrier and higher exposure to the brain compared with the other EGFR TKIs. Adjuvant osimertinib also demonstrated CNS DFS benefit versus placebo in both the stage 2 and 3A and 1B to 3A population. And we also see the separation in DFS analysis. The hazard ratio was 0.24. That is also much significantly and very significantly demonstrated in stage 2 to 3A. Next, please. And if we see the safety analysis, thus all the adverse event was all taken care without any significant mortality. Mortality we have not seen in both the arms. There were some grade 3 adverse events in osimertinib arm, but may be related to the immune related or diarrhea, though kind of thing. Discontinuation was little higher with the 43 patient, like 13% compared to 3% in placebo. As we all know that is it maybe because of immune related toxicities. But overall, the all side effects were properly managed and controlled. Next, please. So we have to take away the points very importantly that there is, in order to improve the survival, we need to put more efforts to identify lung cancer early. Number one. Number two, never miss an opportunity to test for actionable mutation. And this is now applies even in the early stages, and especially we have to see for EGFR because we have drugs for that. There should be a collaboration with multidisciplinary team. It is the key point, and it is to improve the survival of the patients. Next, please. And the patient may ask for the treatment option for best survival probability. So we should be ready to discuss and offer them as per best available data. And ADORA data gives a probability of patients to remain cancer-free along with survival benefit. That is really wonderful. And being cancer-free is a goal of patient as well as his or her treating physician. Next, thank you very much. Thank you, and sorry for the inconvenience taken by the network issues. Thank you.
Thank you, Dr. Shyam Agrawal, sir, for the very crisp and sportingly positive thing that is because of the network issue. Then you have come back and started again. So it's good. And
Thank you.
Thank you for the elaborative session. May I now request Dr. Bharat Vaswani? Dr. Bharat is a very good friend of mine, and he is the director at Yashoda Hospital, Sikandrabad. One of the most learned medical oncologists, I can say. Few times whenever I feel it's tough, then I give him a ring. Dr. Bharat, what we do now in this situation? So may I now invite Dr. Bharat?
Sir, first of all, am I audible, sir?
Yes, you are audible and visible,
sir,
but not visible.
Yeah, my screen has some problem. So first, apologies for that. But I'm clearly audible, sir. That is more important. And the slides are visible?
Yeah, slides are visible and you are audible, but not video.
Screen, you have to pardon me this time, sir. Some problem in my screen now. So I'll try to correct it. But let me start. Sir, first let me thank Rakesh Taran sir. Sir is senior to me. I was sir's resident. He was 2 years senior. So I had a pleasure of working under Taran sir, learned a lot from him, and it is now basic more than 15 years now. But sir continues to inspire us with the work sir is doing. My talk in the next 15-20 minutes is I have tried to cover lot of things, but in a short period of time. If somebody has gone through the recent updates in WCLC, which was in the month of September, and subsequently we had a ESMO, what is new in the lung cancer outlook? So 9 simple take-home messages I'll be giving it. Something that you need to remember, I am not giving him any drug treatment. This is all, if you go through your YouTube also, there is a Onco Brothers, they do a lot of things, and I have tried to take this, not a slide, but what are the main studies, so that I'll be discussing in the next 15 to 16 minutes. So the first question, is there something more potent than immunotherapy in a non-small cell lung cancer? Look, 10 years back, we had chemos. Immunotherapy changed the way we looked at lung cancer, Pembro, Nivo, Atizo, Durvalumab. Now the thing has come at that probably we will be moving one step more than immunotherapy. And that is the most talked about study in this WCLC and including a ESMO. So the next big thing. So a phase 3 study, please remember this is phase 3. That is why I took it as the first. A phase 3 study of ivonescimab versus Pembro as a first-line treatment in PD-L1 positive advanced lung cancer, the first analysis of Harmony 2 studies. So a head-on comparison with Pembro versus ivonescimab for those who have PD-L1 more than 1 TPS. Now a new molecule. So what is this new molecule? So now is the age in lung. You have a amivantamab, that is a EGFR plus MET. This is a bispecific antibody combining PD-1 with VEGF. So basically you are telling at one end it is PD-1 and other end it is VEGF. So you are combining basically with a bevacizumab, you can say. And it simultaneously engages both PD-L1 and VEGF. So a first-line study with no prior treatment, non-driver mutation. Randomized to ivonescimab 20 mg per kg 3 weekly versus pembrolizumab. Treatment 3 till disease progression. The main endpoint is PFS and OS. Now this is a bigger number if I go through it. So twice the improvement in PFS as compared to pembrolizumab, a 49% reduction in the risk of progression. This is a bigger number. Think of non-driver 11-12 months in more than one. I'm not talking more than 50. So a drug which is twice better than pembrolizumab. Now, how is the quantum of benefit in 1 to 49 and 50? Squamous and adeno. So if you look into the hazard ratio, it is around 0.50. So irrespective, 1 to 49 more than 50, squamous, non-squamous, this drug is twice better than what pembrolizumab is all about. Wait for some time. Now we have a data. We are getting a data of this drug with chemo, this drug combining with other. So you will have lot of exciting data with this drug called as ivonescimab. What are the side effects? So side effects are more where you have an anti-VEGF like proteinuria, hypertension, and laboratory abnormality. But when you talk about discontinuation or grade 3 manageable, discontinuation less than 2%. So we have a drug probably which has come in a phase 3 sitting, which is probably better and Pembro. And in future, you will see a lot of these studies and we will be eagerly awaiting this drug to come to India. So the first randomized phase 3 study to demonstrate a clinically significant improvement in efficacy with the novel drug compared to Pembro, and probably a novel first-line treatment of patient with advanced NSCLT and positive PD-L1 with a TPS of more than 1. So probably this is the most important study I wanted to present. Then the tale of datopotamab deruxtecan. This was in a second line. We already had this data of PFS, Tropion lung study. What this study suggested is better response rate than docetaxel in the second line, post-immuno and chemo. And there was a statistically significant improvement in progression-free survival. That was in non-squamous and SQ. What this study showed is whether there was an improvement in OS. So the main thing that we always talk about. So those patients who had no prior dosi had taken 1 or 2 lines, including chemo and PD-L1, dotemotamab, deruxtecan 6 mg per kg 3 weekly versus dosi. Big study, N is 300 around. PFS and OS. We have a data of PFS. OS, no statistical improvement. Again, telling that docetaxel still is one of the best drug available. You should not worry about when you give a Taxol in the second line. Now, no significant improvement in OS. Now, improvement, there was some trend towards improvement in OS in adenocarcinoma. So 14.6 versus 12.3, around 2.5 months improvement with a hazard ratio of 0.8 for 16%, but it crossed unity. So I may think of giving a non-squamous, not absolutely no squamous. The thing is, the only take-home message, or yes, I may use this when it is available because the toxicity is significantly less than docetaxel. So a drug with a better PFS, not better OS, but trend towards better OS in adeno, but a safer drugs in terms of toxicity, dose reduction, treatment discontinuation. So a good safe drug available. So what this trial Tropion-01 is, it met its primary endpoint of improvement in PFS, numerically better OS, but not statistically significant, consistent benefit across all lines, that is in non-squamous, and tolerability is something that I may think of giving this drug, probably a better drug in terms of tolerance, but yes, no improvement in OS. And docetaxel continues to hold its place normally. So the second study. Now there are three things that has come. This is a drug, I think is a very good drug, amivantamab, a drug which target EGFR and MET. Remember your immunity that was PD-L1 and VEGF. So now is the age what we are getting more of a bispecific antibody. Now think what is the most important side effect you think when you give a drug amivantamab. So 60, 70%, the first dose is horrible. You can't give this drug without the presence of a doctor because 7 of the 10 will have an infusion-related adverse event. It is a dictum probably rather than an exception. So infusion, you have to be sure. Amivantamab day 1, you have to be there beside the patient. So a new study that came is, can we reduce infusion-related adverse event? So a SKIP study, SKIP SKIP study, 3 arms. One arm contained dexamethasone for 1 day. The other arms are given dexamethasone 8 mg day 3, day 2, day 1, and 1 hour before treatment. The third arm gave methotrexate or montelukast. It was standard dose of amivantamab, and the primary endpoint was infusion-related event, IRR. So what they observed, to cut the story short, 1/3 of the adverse events when you give dexamethasone 8 mg on day 2, day 1, and 1 hour before you start amivantamab. So probably what we learned is you can treat it better when you start a pre-dexazone for 3 days. And now we'll having, you remember your drug daratumumab or what we have Phesgo. Now a new form of subcutaneous amivantamab is coming, probably will come in 6 months. This was again a Paloma study, not a palbociclib, but in future we will have a subcutaneous form which has already been launched. Once it comes to India, the side effect profile will come down by more than 70% when you get a subcutaneous form. The fourth study, somebody was discussing before, in preoperative or perioperative or early stage lung cancer, we know that chemo plus IO is the standard of care. Now there is a debate whether you should give only checkmate 817, what we give 3 cycles of chemo, nivo, followed by surgery and okay, or 3 cycles surgery and then completing 1 year, that is 12 to 13 doses of nivolumab. So can anybody tell me which is the better approach? So we don't have a phase 3 study. So the question $1 million is, which approach is better in NSCLC? Is it a neoadjuvant or a perioperative approach? So this was again a most talked about study, perioperative versus neoadjuvant nivo for resectable non-small cell lung cancer, patient level data analysis. Remember, you can never have a study which will be done now. You need to go through the lines. So patient level data analysis of checkmate 770 versus checkmate 816. So in one, they compared 3 doses, and those patients who have taken at least 1 dose of adjuvant nivolumab, they tried to see what is the event-free survival. So again, indirect, they tried to compare it. And what they saw was, there is absolutely no doubt, perioperative has to be given rather than 3 doses of preoperative, and there is a 41, probably a 39% improvement or reduction in event-free survival when you are using a perioperative approach. So perioperative approach probably better than only a neoadjuvant approach. So 3 followed by 12 to 13. Now, there is always a debate. Even I have attended so much panel that suppose if I get a pathological CR, I may not use it in a post-op setting, and that is why we call. But this study says that your quantum of benefit remains the same. See your pathological CR, 0.58, no pathological 0.38. So perioperative better approach better, irrespective of whether it is a PET CR or non-PET CR. So you need to give all your patients. Now, the only thing which actually it was a surprise for me, but this is what the data says, that if your PDL1 is more than 1, the quantum of benefit of giving post-op nivolumab is not much. So that was something that they tried it to debate. So patient with a PDL1 of less than 1, you have to give it irrespective of PDL1. But if your PDL1 is more than 1%, advantage of perioperative is doubtful. That was the only subset. I would be more interested in knowing what is more than 50% here. So probably you can basically tell that probably in that patient, you may give only 3 doses of nivolumab in a pre-op setting. So what did this study concluded? It represents the only comparison of perioperative and neoadjuvant immunotherapy approach. 40% reduction in the risk of disease recurrence of death after surgery when you have given at least 1 dose of adjuvant therapy. So probably, yes, there is a similar benefit regards whether it's your PCR attained, not attained, but some doubtful benefit when your PDL1 is more than 1. Less than 1, yes, it continues to benefit. Perioperative event-free survival benefit versus only neoadjuvant chemo, and it has a manageable safety profile. So yes, if possible, patient can afford, give the entire 1 year, 3 doses before and subsequent surgery, the remaining 12 to 13. 4 studies I discussed, I'll tell you in the take-home message in this WCLC. But ivonescimab, remember this drug, it will continue to come in every conference and with new combination. What about ESMO 2024? Any new studies? There were 4 or 5 studies, but it is mostly a disappointment according. There is nothing called as blockbuster, but some studies where we got some more data about. So a LAURA study, you have ADAURA, you have FLORA, it was a LAURA. LAURA is locally advanced, unresectable. Post-CTRT, you give osimertinib lifelong. Remember, it is not 3 years, it is still progression versus placebo. So locally advanced, unresectable, stage 3 exon 19, 21, osimertinib was really till progression. Primary endpoint was PFS, secondary endpoint was OS. So this study showed was at the end of, you see, 2 years, if you have not given osimertinib, only 13% is disease-free. These are bigger. So it is no doubt or no brainer that you need to continue your EGFR post thing. This was what, it is not the primary. It was previously discussed. See the PFS, 39.1 versus 5.6. A biggest family, 84% reduction in the risk of progression. So you don't have to think twice when it is unresectable. CTRT, osimertinib. Now, what are these? Only why 13? So there was a subset analysis in this ESMO about CNS. Now, the most important thing, if you don't give your EGFR drug, 57% of the patient will relapse in brain by the end of 2 years. So that is why the main advantage of osimertinib everywhere is when you, by reducing the CNS mets. So that is something versus 83% when we are giving a osimertinib. And when you look into CNS events, it is more than twice when you have not given your osimertinib. So what this study shows that you need to give it, and the main quantum of benefit is by reducing your CNS events. And it was statistically significant, same hazard ratio of 0.17. The 634 Mariposa study. Remember your Mariposa study. There is Mariposa 1, Mariposa 2. Amivantinib, lazertinib versus osimertinib versus lazertinib. Please remember, lazertinib probably we may not be using in future, so you should not break your heads on lazertinib. There is a high incidence of thrombotic event. So probably lazertinib basically is discouraged. Treatment naive in advanced NSCLC, we know that amivantamab plus chemo in Mariposa 2 or now in other probably better, and in amivantamab and lazertinib is also statistically significant. This study, you remember amivantamab is what? EGFR plus MET bispecific antibody. So they wanted to see what is the relapse pattern. So what they observed was, it is 1 slide only. When you are giving this drug, the commonest resistant mechanism when you give osimertinib is MET amplification, which is statistically or nearly reduced. The most important mechanism probably is the secondary EGFR resistance. So we might start doing a liquid biopsy. We'll have more of these patterns, but the main take-home message is your MET amplification is drastically reduced when you give amivantamab as compared to osimertinib. And MET amplification is probably the common resistant mechanism and a single agent osimertinib. The second study, Mariposa 2 study. Remember, this study was in a second line setting post single agent osimertinib progression. So we need to look into amivantamab plus chemo versus chemo. Now, we know that there was an improvement in progression-free survival, which was statistically significant. Now, what is more important is, yes, this combination has to be given because this combination statistically improves your overall survival. So at 18 months, 50 versus 40, 10% more patients are surviving. The absolute gain of 2.4 months, a 27% reduction in the risk of death. I have started using it as a very good drug, provided if your patient can afford. Hypersensitivity is something you need to worry. The second, there are so many soft points are there. Time to treatment discontinuation, time to second PFS, these all were statistically significant. But the median progression, if you see, time to is 10.4 months versus 4.5. At 18 months, 5 times more patients are on treatment at 18 months in a second line setting. So if you respond well, you keep on responding for a long period of time. So at the second interim analysis, there was a statistically significant improvement in the OS and other like time to treatment progression, discontinuation, subsequent therapy, all are statistically significant. So if I'm using a single agent osimertinib, the second line best drug is amivantamab plus chemo. There is a doubt if you use now, since we have a data of FLORA2 which says that give pemetrexed, carbo and OC in the first line. What will be the second line best along with amivantamab? That question still needed to be answered. Adriatic study. You have a Pacific study post CTRT in non-small cell. Corresponding is an Adriatic study in small cell lung cancer and a limited stage
Bharat
small cell
sir,
lung cancer.
sorry to interrupt. Kindly
Yeah.
conclude your talk, please.
Yeah, there is already 2 trends. That is important. So durvalumab, 1 year OS and PFS. So whether the OS changes, whether you give a PCI or not. So this suggested that irrespective whether you give prophylactic cranial irradiation, there is a statistical significant improvement in your OS. So probably challenging the road whether you require really a PCI when you have a limited stage as a consolidation. The last, you have dabrafenib, trametinib. There is a new combination in BRAF V3 mutant as a first line is NSCLC. We have this drug in colon. Now this drug is also approved in non-small cell. So cohort A, first line treatment, overall response and PFS. 65% response, 85% disease control rate. So these are bigger and better number. Think of a drug in a first line going such an amazing response. A 10.9 months progression-free survival, probably one of the best you have seen. So this drug is probably a challenge to dabrafenib, trametinib. Once this drug is available in India, this will be one of the best drugs to use. And you have 2 now different options present when you have a BRAF and a first line in a non-small cell lung cancer. So if I have to give my 9 take-home message, ivonescimab more efficacious than pembrolizumab in patient with PD-L1 of more than 1. Datopotamab deruxtecan has a better PFS than docetaxel and adeno. However, OS not significant, but there is a trend to better OS. 3 days pre-medication with steroid reduce infusion-related side effect of amivantamab by 1/3. Perioperative approach better than just a neoadjuvant approach in early NLCLC, maybe including those who achieve a pathological CR. Osimertinib reduces recurrence mainly by better CNS control as per as LAURA study. Pattern of acquired resistance to amivantamab plus lesetinib is by secondary EGFR mutation, not by MET amplification as such. Ami plus chemo versus chemo in patient with advanced non-small and EGFR mutant improve your OS with a 27% reduction in the risk of progression. Durvalumab as consolidated therapy in limited SCLC, improvement in OS irrespective of prophylactic cranial irradiation. And last but not the least, encorafenib and binimetinib, a valid and effective first-line option in BRAF V600 mutated NSCLC. You have 2 now combination available. And I end my talk with a famous quote of Socrates, again, my favorite. The secret of change is to focus all your energy, not on fighting the old, but on building the new. I thank you all for a patient hearing.
Thank you, Dr. Bharat. it was really good to have the gist of WCLC and ESMO. Very crisp presentation and very knowledgeable. I feel all the attendees would agree with this. And thanks once again, Dr. Bharat. May I now invite
Thank you.
Vikas Asati, sir. He is the medical oncologist and professor at Arvindo Institute of Medical Sciences, Indore. Good friend of mine. And may I invite him for the talk of evolving evidence for the multiverse of HR positive, HER2 negative ABC patients. To you, Dr. Vikas.
So thank you, sir, for giving this opportunity. Hope I am audible and my slides are also visible.
Yes, sir.
Yeah. So good evening,
Absolutely
everyone.
audible.
Yeah. So the topic that has been assigned to me is the evolving evidence from the multiverse of HR positive, HER2 negative advanced breast cancers. So the slides have been provided by Novartis. So as we know that the treating ERPR positive and HER2 negative breast cancer is a challenging. It is not like TNVC where you have to give one chemotherapy after the other. So the key consideration for treating such patient will be patient-related factors like quality of life, prolonging the survival, the disease-related characteristic. Also, we need to see whether there is a impending visceral crisis or not, whether this patient is clinically aggressive, something like the endocrine resistant patients, and also what the patient has received and how they have responded to the previous lines of therapy. And based on these factors, we need to decide the therapy which will be optimal for our patients. So as if we see the guidelines, whether ESMO or NCCN, and for that matter, any guidelines, if there is no impending organ failure or no visceral crisis, endocrine therapy plus CDK4/6 inhibitor are category 1 recommendation. Although we have a data based on right choice study that even in patient of visceral crisis, the combination of endocrine therapy and ribociclib works very well, that we will discuss in the subsequent slide. But apart from these patients, and most of the patients where there is no visceral crisis, I think there is no doubt that endocrine therapy, something like aromatase inhibitor, either letrozole or nastrozole, with either of the CDK4/6 inhibitor is the way to go. Once patient progressed on this therapy, then comes the role of the acquired mutation. What kind of mutation is acquired? Something like PIK3CA, or if our patient is having germline or somatic BRCA or PLB2 mutation, and all these patients we can use PARP inhibitor. So once patient progressed on first line of therapy, the things are really difficult. Coming to the data that we have, so for first line therapy, we have a data from Mona Lisa, Paloma, and Monarch 3 trial, and they are respectively studied the ribociclib, palbociclib, abemaciclib. So if you see the hazard ratio for all the three phase 3 trial, it is almost same, and you can see that it is 0.5, 0.56, 0.58, and 0.54. So it appears that there is no difference between the three CDK4/6 inhibitor if we concentrate on PFS. But what we want that our patients should live longer. The PFS is one part of the efficacy parameter. If some drug is giving the PFS and OS, I think then that should be the best. So if we see the first plot for all the same trial, and if you see the overall survival data, and you can see that there is only one drug which is showing the significant improvement in survival, and with the hazard ratio of 0.76. So here the ribociclib looks a clear winner. Coming to the toxicity. So as far as toxicity of ribo and palbo is concerned, I think both look same. But when it comes to abemaciclib, the diarrhea is really worrisome. So we have to be very careful. Coming to the quality of life, so this is also very important. How, although the patient is surviving more, but how, with the what quality of life? So again, we can see that all the three CDK4/6 inhibitor, there is an improvement quality of life, except abemaciclib, where you have increasing worsening of diarrhea. Otherwise, either you take ribo or pelvo, both looks okay. Coming to the guidelines, so if we see the ESMO guidelines, they always give some scoring, and that is ESMO MCBS scoring, and they give between 3, 4, and 5. So if you see the ribociclib in postmenopausal and premenopausal patients, the score is 4 in postmenopausal and 5 in premenopausal patients. So if we have a premenopausal patient, I think the only approved CDK4/6 inhibitor is ribociclib. And in the postmenopausal, the score for ribo is 4, and for pelvo and abiba is 3. And I think why ribo has more score than other two CDK4/6 inhibitor, and I think they have the better OS data. Coming to the next one, the why ribo. So there is a translating preclinical evidence into clinical benefit. So there is a OS benefit across studies, better quality of life, and efficacy across difficult to treat subgroups like patient with visceral metastasis, patient with CNS metastasis, patient with higher disease burden, something like having more than or 3 visceral metastasis. So how do we make life easier for our patients? What are the evidence that we have to see? So we have a different group of patients, like patient with bone only metastasis, patient with elderly age, and then with liver diseases, visceral metastasis, CNS metastasis, and all type of permutation and combination are there. So we have to see whether this drug is working in each type of difficult to treat subset or not. We'll start with bone only metastasis. So this is the graph. This is the exploratory analysis from MINERSA-2 trial, where they compared the median OS of ribociclib plus letrozole versus letrozole alone. And you can see the median OS was almost 6 years with ribo plus endocrine. So 6 years is, the stage 4 patients, the 6 year is a big number. So even benign condition like liver cirrhosis, CCF patient, they also do not survive for 6 years. So this is about bone only metastasis. Now coming to elderly patients, we have enough data that elderly patients can also be subjected for CDK4/6 inhibitor. We have apparent doubt that these patients might have more neutropenia, but it has not been shown. Sometimes I also start with some lower dose and then increase as tolerated. And here again, you can see this is the pooled analysis of MONALEESA-2, 3, and 7. More than 5 years of median OS was observed in all age group treated with ribo plus endocrine therapy, including elderly, that is age more than 75 years. Now coming to liver metastasis. So we know that liver, apart from for such group of patient after the bone, I think the second important organ which has been affected is the liver, and I think after the liver is the lung. So if you see the liver confined metastasis, there is 29% relative reduction in the risk of death was observed with ribo plus endocrine therapy, with median PFS increased from 35.4 to 39.6 months with the hazard ratio of 0.71. Coming to the visceral metastasis, here also you can see the multiple visceral organs are involved, but also hazard ratio is 0.78. The endocrine therapy survival is 51.8, and ribociclib plus endocrine therapy median OS is 63.4. So almost more than a year of difference if we start with CDK4 plus endocrine therapy. Coming to the patient with CNS metastasis, so we know that these group of patients really rarely metastasize to brain and contrary to HER2 positive or TNBC patient, which has higher propensity for brain metastasis. So if we don't have much data, so what they have done, there was a phase 3 real world, that is the phase 4 trials. They have taken out the data, and out of more than 3,000 patients, there was only 51 patients which had CNS metastasis, and they tried to see how these patients are doing with first line endocrine therapy. And here you can see that time to progression was 27.1 months. So we know that these patients are difficult to treat, but even with even in these patients also, or around 2 months of PFS was event-free probability is around more than 2 years. Coming to the more than 3 metastatic sites, so not only single organ is confined, more than 3 sites have been involved. Here again, you can see there is 27% relative reduction with hazard ratio of 0.7. So this was the study I was discussing on my first slide, the right choice study. And what they did, I will show. One slide is missing. So what they did, they subjected the patient with impending visceral crisis to either combination of chemotherapy versus ribociclib plus endocrine therapy, and you can see the median PFS almost double, 12.3 months versus 24. So these subset of patients can also be subjected for CDK4 plus endocrine therapy. But I have tried this combination in few patients, and I think 1 out of 3 patients, we can skip the chemotherapy. But in 2 out of 3 patients, somehow I need to give some chemotherapy, and then I need to continue on ribociclib plus endocrine therapy. Coming to the Asian patients, so this data was new for me, that they try to see how the Asian and non-Asian was doing with ribo plus endocrine therapy. The PFS is more better in Asian patients. I don't know what is the reason, but the hazard ratio looks more better for in ribociclib plus endocrine therapy, at least in right choice trial. So based on this study, there was a consensus statement that came in ABC 6 and also in the 7 guidelines, that these results reinforce the place of endocrine therapy plus CDK4/6 inhibitor is a standard of care for first line therapy for majority of patients with ER positive and HER2 negative ABC, including those with clinically aggressive disease. And last is, I think this is the most difficult subgroup of patient, the endocrine resistant patient. So if someone is receiving endocrine therapy, and if they progressed very fast within 2 years of endocrine therapy, believe me, they are the worst group of patients, even more worse than TNBC, because they always have very poor PFS and survival. And you can see the TKI are not same. So we have to be very careful. The hazard ratio is different. Again, the same thing is depicted here. Hazard ratio is different, and hazard ratio for ribociclib in MONALEESA 3 and 7 is 0.7 and 0.59 respectively. So the last slide, the key takeaways: does choosing ribociclib makes life easier? So I think answer is yes. There is a ease in not worrying about the ribo would be effective and low burden or high burden patient. There will be ease in explaining overall survival to our patients. There will be ease in titrating dose as per the clinical status of our patient. And there will be ease in ensuring good efficacy while maintaining a good quality of life for our patients. So this is all from my side. Thank you so much.
Thank you, Dr. Vikas. I think we all would agree that ribociclib plus hormone earlier to start is a good way to go through. There are 2 questions or requests from Dr. Vikas. Any subset of patient where you will not prefer using ribo upfront? And second is,
yes, sir. Please continue.
Second is, if the patient has progressed on the combination, is there any subset where you prefer to go ahead with ribo with some other thing?
So basically, the first question was the subset of patients where I will not use ribo. So patients with hepatic dysfunction. So we know that around 10% of patients can have hepatic dysfunction with ribociclib. So I will be careful. And there is a theoretical concern of QT prolongation. So if someone having history of arrhythmia, I will be careful. But somehow we have done lots of ECG, even a single patients where we have stopped the ribociclib for QT prolongation. At least I don't know if someone has stopped. Please, you can share your opinion. And the second question was about the continuation of ribociclib. So I'm not aware about the data of continuing ribo after ribo, but we have a data that if someone has received palbociclib, and when they progress, they change to ribo and change the endocrine partner to fulvestrant. There was a better PFS. So if someone is on other TKI, I will be happy to change to ribo. So in that trial, the number of patients who was receiving ribo and continued ribo was around less than 5%. So I will be careful. But majority of patients was receiving palbociclib. So I might change to ribo plus fulvestrant.
Thank you, Dr. Vikas.
Thank you, sir. Thank
Any
you.
other questions from the participants or from the audience? It's most welcome. For next talk, may I invite Dr. Shaunak. Dr. Shaunak is a consultant medical oncologist at JNCH Bhopal. And I think Dr. Shaunak is here.
Yes, sir. Good evening, sir.
Hi, Shaunak. Actually, you're not visible, so I thought, are you there or not?
Yes, sir. Yes, sir. I'm here.
Shaunak is going to have.
Yeah, Shaunak, I'm sorry. I did not allow you to present
That's
your
okay, sir.
presentation before mine, because you know the boss is same everywhere.
Yes, sir.
So the talk Shaunak is going to have is optimizing the management of HER2 positive metastatic breast cancer. Dr.
Yes,
Shaunak.
sir. Thank you so much, sir. Can the organizers please share the slides? Yes. So today we'll be speaking about the experience with dual HER2 blockade in HER2 positive breast cancer with focus on FESGO. Next slide, please. So these are the disclaimers. And next slide. So the benefit of PAT-CR in the neoadjuvant setting is very well known both in the TNBC setting and the HER2 positive setting. We have multiple meta-analysis and retrospective studies which have shown that those that attain a PAT-CR have an event-free survival advantage, a DFS advantage, as well as an OS advantage. So for our patients, we must do all that we can to try and give preoperative therapy to attain a PAT-CR. Secondly, we know that the difference in survival benefit of PAT-CR is with a hazard ratio of 0.48 as per the CT-NEO BC analysis, and it translated into an OS with a hazard of 0.36. Next slide. So when we started off with chemotherapy for HER2 positive, it was a very dismal outcome where we only had chemotherapy. After the advent of trastuzumab, we started achieving a pathologic complete response around 35 to 40%. With the addition of pertuzumab to trastuzumab, we are achieving pathologic complete responses in more than half of the patients. And in the latest trial that we have of ADAPT HER2, where pertuzumab plus trastuzumab was given with weekly paclitaxel, it has attained a PAT-CR of 90.5%. But we do follow the Neosphere and the Trifina data, where almost 60 to 70% patients with the dual HER2 therapy attain a PAT-CR. Next slide, please. So what is the benefit of neoadjuvant pertuzumab plus trastuzumab? So first is the improved event-free survival compared to those treated with neoadjuvant trastuzumab. Secondly, there's always a decision where after the use of dual HER2 in the neoadjuvant setting, do we continue the dual HER2, or do we step down to a trastuzumab alone setting? So this was a trial that was done where we analyzed the effect of trastuzumab in neoadjuvant, followed by trastuzumab in adjuvant. That was the HANA and the Neosphere part of the study, where 30.9% of patients had an event. This was regardless of PATCR. When the addition of pertuzumab was given only in the neoadjuvant setting, such as in the Neosphere and the Trifina, only 18% of patients achieved an event. Whereas in the Berenice and Christine study, where pertuzumab was used throughout, that is in the neoadjuvant and the adjuvant setting, only 5.6% of patients had an event. So this goes to show that the event-free survival with the use of pertuzumab throughout the phase of neoadjuvant and adjuvant improves the event-free survival. Next slide, please. So regardless of PATCR, the reduction in EFS benefit was greater in patients that have been administered a dual HER2 therapy in neoadjuvant plus adjuvant versus those that have been administered only trastuzumab in both the settings, and the hazard ratio for the difference was 0.36. Whereas those that received pertuzumab only in the neoadjuvant setting also did have a benefit with a hazard ratio of 0.67. But the depth of the hazard was deeper with the use of pertuzumab throughout in the neo as well as the adjuvant setting. So this was a pooled analysis from the multiple trials. Next slide, please. So again, the process of receiving IV chemotherapy places a significant burden on the entire life of the HER2 positive breast cancer patients. Patients try to maintain a positive view towards IV infusion therapies. However, there is always a risk of adverse reactions. There's always the time which can be cut down on due to newer formulations of drugs that have been available. So on digging deeper, IV infusions were found to have placed a significant burden on the lives of HER2 positive patients in terms of logistical and time burden, pain, and emotional impact. Next slide. And the nature of burden faced by patients is that it is also dependent on the stage they are in their infusion journey, plus the outlook that they have with regards to the positiveness, which is always a major component on how the treatment responds, as well as their own life circumstances and the emotional and financial support that they have. Next slide. These logistical challenges result in a range of negative emotions for breast cancer patients, such as anxiety, frustration, guilt, and isolation. We have a lot of patients who are continuously reminded of negative outcomes, and their focus is on the negative rather than the positive. The frustration of waiting time and the infusion time, the guilt on how everybody on the family and friends are focused on their caregiving, and they cannot return the favor to their other friends and families, as well as isolation because they feel that they must not mingle with their friends and family. Next slide. So in studies done to assess the impact of depression and anxiety on survival, depression was associated with cancer recurrence, all-cause mortality, as well as cancer-specific mortality. Comorbidity of depression and anxiety is associated with all-cause mortality as well as cancer-specific mortality. Next slide. So we have the Berenice trial, which is the study on the true long-term survivors of the disease. The major impact of the use of dual HER2 in terms of PATCR and event-free survival, the threat was whether the cardiac safety profile would be tolerable for patients over a longer period of time, and this was what was assessed in the Berenice trial. So they used neoadjuvant trastuzumab plus pertuzumab in the neoadjuvant setting, as well as pertuzumab in the post-surgical setting as well. After a median follow-up of almost 65 months, the cardiac safety was shown with no incidence of class 3, class 4 heart failure. And only one patient in the adjuvant setting developed a class 3 heart failure. The 5-year EFS rates were 90.8 and 89.2 respectively in cohorts A and B, and the OS rates were 96 and 93% respectively. Thus, the Berenice data shows a high proportion of patients with no disease recurrence at more than 5 years of follow-up. Next slide, please. Next slide, please. Yeah. So there was the Peony trial that was done, which assessed the long-term efficacy endpoints of EFS, DFS, and OS, which was supportive of the primary endpoint of PATCR, and a clinically meaningful benefit with the addition of pertuzumab to trastuzumab was found. More than 70% of patients in the dual HER2 arm and almost 70% of patients in the placebo arm experienced grade 3 or higher adverse events. Most common that were more than 5% in each arm were neutropenia, leukopenia, and febrile neutropenia. Diarrhea was more common in the pertuzumab arm. But in terms of EFS, DFS, and OS, the EFS was statistically significant with a delta of 9% at 3 years, increasing to 11% at 5 years. The OS, the delta at 3 years was 6%, whereas the delta at 5 years was 3.9%. So this did not translate into a long-term benefit. But there is no doubt with the use of neoadjuvant pertuzumab in HER2-positive breast cancer. Next slide, please. So what is the current status of dual HER2 blockade? Next slide. So all the guidelines recommend the preferred use of a dual HER2 setting, whether it is the preoperative or the adjuvant therapy setting. If there is no residual disease after NACT, we can continue up to 1 year of treatment with trastuzumab plus minus pertuzumab. If there is residual disease, then TDM1 is category 1. Next slide. In the adjuvant setting, adjuvant chemotherapy with trastuzumab and pertuzumab is category 1 in the node-positive setting. We have the affinity trial which showed that those with N2 or N3 disease had the maximum benefit with pertuzumab. Next slide. In the HER2 in the adjuvant, yeah, this is the same. Can we have the next slide, please? Yeah, so the ESMO guidelines also show that for clinically T2 or N positive, we need to go for a neoadjuvant treatment, and those that are T2, that are T1, can be given upfront surgery. Next slide, please. So the IV infusion of pertuzumab and Herceptin is well established, but presented various challenges to the patient. One was the infusion time, the congestion at clinics and hospitals, challenge of improving resource utilization, indwelling venous access, and the challenge of venous access in all these patients. So the infusion of both gives a time of about 2 to 3 hours. And this can be reduced with the use of a subcutaneous formulation. Next slide. So Phesgo, which is the first formulation to combine 2 monoclonal antibodies in one vial for subcutaneous injection. And it is formulated with recombinant human hyaluronidase to allow subcut administration at higher drug volumes, 15 ml loading dose and 10 ml maintenance dose. And it is a ready-to-use fixed dose formulation given over 5 to 8 minutes. It is administered subcutaneous in the thigh. Next slide. So the main reasons for preferring subcut administration is that it requires less time and in the clinic and feels more comfortable during administration. Next slide. So the majority of healthcare professionals also feel that switching from IV to Phesgo reduces time and saves resources during preparation and treatment. Next slide. So 66% of patients felt restricted when using the IV drugs compared to only less than 30% when receiving Phesgo at the primary analysis. So the psychological impact when receiving IV was much higher compared to receiving subcut formulation. Next slide. So the 2 innovative molecules in one single dual blockade shot, it was the Federicia trial, which demonstrated non-inferiority of cycle 7 pertuzumab level and pre-dose cycle 7 trastuzumab level within Phesgo versus the IV pertuzumab plus trastuzumab treatment. The PATCR rates were almost identical between the two arms, and Phesgo was well tolerated. In the Francesca primary analysis, 85% of patients preferred Phesgo over the IV. The safety profile was consistent with previous use and no safety signals. After long-term follow-up, efficacy data remain immature, but high 3-year IDFS and OS rates are seen. Next slide. So we are prioritizing patient safety with the use of Phesgo, where with the use of Phesgo, there is lesser incidence of adverse events like diarrhea, injection site reaction, fatigue, and arthralgias. Next slide. The summary of adverse events by treatment regimen and body weight quartile for irrespective of the body weight and adverse events was similar in both treatment arms. Next slide. So assessment of the cost effectiveness of HER2 targeted treatments in the neoadjuvant treatment was also analyzed. So neoadjuvant targeted therapy versus fixed dose combination of Phesgo, and adjuvant target therapy if PATCR is achieved, adjuvant target therapy in the case of residual disease. Next slide, please. So with the use of fixed dose, the total lifetime cost was lesser compared to the use of IV drug combination. Next slide. So the conclusions were that neoadjuvant treatment with fixed dose combination is cost effective. The adjuvant continuation of fixed dose dominates all strategies, and we have those strategies coming in with the effect with amivantamab as well, as we discussed. While it is costlier than strategies in which IV pertuzumab is discontinued after achieving PATCR, these additional costs are generally low relative to the clinical benefits obtained. Next slide. So now we do what the patients need next. Next slide. Thank you.
Thank you, Dr. Shaunak. Just good concept of Pertu and Trans2 in combination in the form of Phesgo. Just two requests. What about your experience with the diarrhea part, which is there with the Pertu?
Sir, I have had diarrhea. Sir, can I just join again? I'm actually on the way to the airport. I need to leave.
Sure, sure.
I will rejoin.
Sure. Till then, may I invite Dr. Akash Tiwari? Dr. Akash is there?
Yes, sir, I'm here. Hi, sir.
Sorry, Akash bhai, you were not visible. So,
Sure.
Dr. Akash is a renowned medical oncologist from Indore, good friend of mine again, and he's going to speak on trastuzumab deruxtecan in treatment of HER2-low breast cancer. Over to you, Dr. Akash, please.
Yes, sir. Sir, is my screen visible?
You're audible, but screen is taking some time to get shared.
Sir, can someone from the can someone else share the screen? Actually, I'm having some problem in sharing.
Akash, now it's visible. I think you can go ahead.
The screen is visible, sir?
Yeah.
Sir,
Slide
I
back.
have shared the slide. Just you can tell me the next slide. I'll just show you the slides.
Sure. Thank you. I'll just open the.
Akash, you're not audible.
Good evening, everyone. Delay from my end. So, the topic that we will be discussing today is trastuzumab deruxtecan, but essentially in HER2 low positive patients. So we know, could change slides, please. Uh, so we know that a large chunk of patients of metastatic breast cancer that we see uh, at later lines we run out of options, and as we go ahead we realize that trastuzumab deruxtecan offers a solution to this lacuna. So what we do, change the slide please. So what we do essentially that we'll look at the background of these HER2 low metastatic breast cancers, look at it. Change the slide please, buddy. Change slide please. uh, look at the background of this disease, the burden, the destiny 4 data, and look at few case presentations that we have. So we know that currently 25% 5-year OS of metastatic breast cancer is 25%, and it continues to remain an incurable disease. Change the slide please. uh, and in this subgroup currently, how we divide these patients is subgroup which are HER2 negative or HER2 positive in terms of HER2 classification. Change slide please. And the HER2 classification essentially is that patients who are HER2 0, 1 or 2 plus with FISH negative are all categorized as HER2 2, HER2 negative versus
Sorry, Akash, to interrupt. You're not audible right now.
Sir, Akash sir is facing some network issue maybe.
Can you ask him to rejoin, please?
Sure, sir. Sure.
Am I audible now?
Yes, please. I think you can just go back to few of the slides, because right from the third slide, your voice was not there. So if feasible and if you're comfortable, can we move back for few slides?
So, uh, so essentially, sir, what we have discussed till now, and I'm sorry for the glitch at my end. So that in hormone receptor positive patients with breast cancer and triple negative breast cancers, in the classical definition, there's a significant lacuna in an option in third line. The next slide, buddy. There's significant lacuna in the option in the third line. So we were discussing that most of the patients uh, in hormone receptor positive, say first line PFS is 28 months, the second line PFS is 16 months, but subsequently the PFS drops to more than 50%. Same is the case with triple negative breast cancer. And we feel that this data of HER2 low metastatic breast cancer gives us an option of treatment for these patients. So, how do we define a HER2 low? It is essentially IHC 1 plus or IHC 2 plus with FISH negative. All these patients are actually are candidates for Enhertu. Could you change the slide, please? And as we'll see subsequently, this almost encompasses 50% of the populations uh, of metastatic breast cancer, which have a very potent third line drug. Next slide. I hope I'm audible now. Manu, am I?
Yes, sir.
So, uh, since Destiny 04, Enhertu has actually become a category 1 recommendation for this subgroup. So, essentially a third line therapy, but with excellent results, and as we see subsequently. Could you change the slides, please? So, how does Enhertu work? The next slide. We know that Enhertu compasses of three components. Uh, there is a component of that resembles trastuzumab that binds to HER2 in the tumor cells. Then there is a cleaver linker, and this cleavable linker essentially binds it to the uh, cytotoxic drug, which is a topoisomerase 1 inhibitor. The next slide, please. So, the target is HER2, the antibody is trastuzumab, the payload is exatecan derivative, and the mechanism of action is it is a topoisomerase 1 inhibitor. See, it is a drug to antibody ratio is 8 is to 1, and there is a tumor selective cleavable linker, uh, and there is a bystander effect. So we see in the next slide what we mean by it. Could you change it? So what happens is that when Enhertu binds to the tumor cells, it is internalized. When it is internalized, the linker cleavage is broken and the cytotoxic payload is released. Now, this cytotoxic payload can actually cross the cell membranes and hence it can kill the cells that are in the surrounding. So, it has a bystander effect, and we feel that a lot of this benefit of Enhertu in HER2 low population is because of this bystander effect. Could you change the slide, please? Next slide. We were discussing this. Yeah, next slide. Next slide. So this is essentially what we were the slide previous, buddy. So this is essentially what we were discussing, that Enhertu is internalized, it is cleaved, and then the payload can actually pass through the cell membrane to the surrounding cells. Could you change the slide, please? Shift to the Destiny 4 data. The next one. Yeah, the design. So we know that Destiny 4, the next slide, Destiny 4 included patients of metastatic breast cancers that were HER2 low, that is FISH HER2 2 plus with FISH negative or IHC 1 plus. These patients had received 1 to 2 prior lines of therapy. If they were hormone positive, they were actually endocrine refractory. Now, they were subsequently randomized between Enhertu and chemotherapy, with the primary endpoint being PFS Secondary endpoint being overall survival in hormone receptor positive and overall population. Of course, the additional secondary endpoint was safety. The next slide, please. So the populations were essentially well matched, and almost 99% of these patients were hormone receptor positive. So 90 to 99% in either groups. So in the overall population, almost 90% of these patients were hormone receptor positive. The next slide, please. So the sites of metastasis at baselines were also balanced. Almost 4% of them had brain mets, almost 30% of them had lung mets, and patients to the tune of almost 70% had liver metastasis also. Change the slide, please. And this is something we see in our practice. So a lot of these HER2 low hormone receptor positives tend to have lung metastasis. And these were very heavily treated patients. So you see that almost uh, almost 67% of these patients had received more than 3 lines of therapy. That almost 37 or 40% of these patients had actually received more than 3 lines of chemotherapy, and almost 27% of these patients had received more than or equal to 3 lines of endocrine therapy. Almost 70% of them had received almost 80% of them had received some very heavily pretreated population. Could you change the slide, please? Am I audible?
Yes, sir.
So thank you. So let us look at the efficacy data, that is essentially the PFS and the OS data. Next slide, please. So look at the primary endpoint of PFS in hormone receptor positive and OS in the same subgroup. So the hazards ratio is 0.51. That is almost a 49% relative risk reduction of progression or death, comparing it with a almost doubling of PFS. Similarly, there is a 6.4 months absolute difference in the OS, median OS, with a hazards ratio of 0.64. So, a 36% relative risk reduction in progression or death. Could you change the slide, please? And one has to note that these are very heavily pre-treated population. In the overall subgroup also, the difference is of 4.8 months in the between the Enhertu and the chemotherapy arm, and almost 6.6 months in the overall survival terms, with a similar hazards of 0.64 and 0.50 respectively. Could you change the slide, please? So, and in terms of the subgrouping, also we see that irrespective of the prior CDK4 uses, the race, age, region, very importantly, irrespective of it, if it was HER2 1 plus or HER2 2 plus with FISH negative, the patients benefited with addition of Enhertu over addition of chemotherapy in the third line setting. The next slide, please. Look at the overall response rate. So we remember that almost 70% of these patients were pre-treated and heavily pre-treated, and we have a overall response rate of 52%, with almost 3.6% patients having a complete remission, which is almost triple than that in the chemotherapy arm. So we have an excellent PFS, OS, and something that improves quality of life, and excellent overall response rate. Could you change the slide, please? Next slide, buddy. The next slide. So essentially says that most of the patients actually respond, something that we had discussed earlier. The next slide, please. So in the exploratory subgroup, in patients who are hormone receptor negative and HER2 negative, so essentially triple negative breast cancers, the median PFS was 8.5 months versus 2.9 months. So, as we had seen, almost triple the PFS, with hazard ratio of 0.46. The median OS was also almost double in this population, and the overall response rate was triple. So NHER2 addition actually benefit the subgroup that was essentially triple negative in our current classification also. Could you change the slide, please? The next slide. So we come to the safety data of Destiny 04, and as we'll see in the slides as Abhimanyu changes it, that the essential toxicity is that of nausea, vomiting, and there's some cytotoxic chemotherapy related side effects like that of neutropenia and anemia. Could you change the slide, please? And diarrhea. But we know that this is not something that is actually troubling most patients or most of the doctors. It is the incidence of the ILD or pneumonitis. And as we'll see subsequently, so we have seen here that the dose reduction rate, interruptions rate are comparable. Same are the is with the dose continuation discontinuation rate. Could you change slide, please? So we were discussing of something that was of concern, and that is of presence of ILD. So we know that in the trial, all patients who had grade 2 and above ILD were actually discontinued permanently. But grade 3 ILD or pneumonitis occurred only in 2.2% of these patients with NHER2, and this is consistent with the previous trials in metastatic breast cancers of NHER2. Could you change the slide, please? So essentially, if ILD occurs, most of these patients will have a grade 1, grade 2 ILDs. Could you change the slide, please? So we look essentially at quality of data, and we see that with the addition of NHER2, the as compared to chemotherapy, there is there is either maintenance of parameters of quality of life, or they remain the same, but there is no worsening because of addition of NHER2. Could you change the slide, please? The next slide, please. So we know that essentially the dosing remains 5.4 milligram per kg. The next slide, buddy. The dosing essentially remains 5.4 mg per kg given every 3 weeks. We start with a 90-minute initial infusion and then subsequently shift to 30-minute infusion in our daily practice. Could you change the slide, please? The next slide. So the dose modification is, is very well defined. It is defined for common complications like ILD, pneumonitis, neutropenia, febrile neutropenia, thrombocytopenia, and left ventricular ejection fraction decrement. Very important to note. So this decrement is mentioned subsequently also. The first step is 5.4, then 4.4, then 3.2. But once we have de-escalated the dose of NHER2, one should not re-escalate. I think this is an important takeaway that one should remember. No re-escalation in NHER2. Change the slide, please. So let us come to the next slide, please. Let us come to the issues of specific adverse reactions. Uh, so the first one that we see is the most important. Remember, grade 3 and beyond ILD is only in 2.2% patients. But if it is grade 2 or greater, we permanently discontinue NHER2. In others, we wait until the ILD resolves. If it resolves in less than 28 days, we maintain the dose, otherwise, we reduce the dose. With neutropenia, febrile neutropenia, thrombocytopenia, in grade 3 toxicities, we interrupt the dose, but when we restart, we maintain the dose. Grade 4 toxicity, we always reduce the dose to one level once it occurs. The next slide, please. With left ventricular ejection fraction, it works almost like other HER2 targetable agents. So more than 45 with a decrease of baseline 10 to 20%, nothing to do. So essentially a symptomatic CHF. Patients with left ventricular ejection fraction less than 40% with a greater than 20% fall, and that fall being maintained after 3 weeks, these two form indications for absolute discontinuation of the drug. For others, we either maintain the dose or monitor these patients carefully. The next slide, please. The next slide, please. Yeah. So the next step is the management of nausea vomiting. So we know that Enhertu is a highly emetogenic drug, and we in our practice offer a 4-drug prophylaxis. Once we have stopped the discussion, we'll discuss how's the practice of other people. But we are practicing a 4-drug prophylaxis in these patients, as recommended by NCCN and is usual practice most places. The next slide, please. The next slide, please. So, as we had already mentioned, we are using 4-drug prophylaxis only in current practice of ours. So, how to manage ILD in a multidisciplinary role? So, this is interesting. First and most important thing in management of ILD is to look for symptoms of respiratory disease, of cough, shortness of breath, and examine these patients. Once we are doubtful, to do imaging for these patients. As we had mentioned, if the patient develops grade 1 ILD, we stop the drug, we see if it resolves in less than 28 or more than 28 days, and based on that, we maintain or reduce the dose. How do we manage it? We essentially manage it with a short course of steroid, apart from other supportive care. But if it is a grade 2, grade 3 ILD, we permanently discontinue the drug. How do we manage it? Symptomatic management plus steroid, as we usually manage ILDs with an acute onset. Change this slide, please. So, in terms of management of ILD, as we had earlier also mentioned, discontinue the drug, add an immunosuppressive, give supportive care remains the mantra of managing of ILD. And I would point out that the percentage of patients developing significant ILD is actually smaller in HER2. The next slide, please. In case of a grade 2 ILD or pneumonitis, as we had mentioned, it should be permanently discontinued. How do we manage it? So it's essentially a copy of the earlier slide that we had seen. Grade 1 asymptomatic ILD, stop the drug, see when it resolves, add steroids, reduce the dose or maintain the dose accordingly. Symptomatic patients, stop the drug, give symptomatic care with immunosuppressive therapy. The next slide, please. So when should it be suspected? I said the most important thing is a respiratory exam. So a lot of these patients would develop, we feel, CREPS early. Uh, Respiratory function test or PFT would be one factor. We all want to detect these patients earlier before they develop actually a hypoxia. But of course, an hypoxia or chest image related changes are pointers to as an ILD. Change the slide, please. So, how are we in our practice doing it? Uh, is that we explain these patients to look out for these symptoms of cough, shortness of breath, fatigue, and to report these symptoms immediately. Uh, we we ensure that we examine these patients carefully in each visits to look for those early Velcro creps. In every second cycle we are getting PFTs of these patients, and if symptomatic then HRCTs in our practice. That's how we are picking that are how we are monitoring for ILDs in our practice. That also remains the standard of care currently. The next slide, please. So we come to an interesting case. It is a 49-year-old female. She has a very strong family history. In February 21, she was diagnosed of having triple negative breast cancer. It was an ERPR negative, HER2 2 plus, FISH negative, clinical T4N2M0, and she's a germline BRCA2 positive patient. She was treated with NACT 4AC 4T followed by right MRM with axillary node lymph node dissection. Remember, this is 2021. Change the slide, please. So in October 21, she develops this pain in the right side of the chest and the axillary area. On examination, there is a swelling here. On PET CT, there is a recurrence with a subpectoral axillary lymph node and a bony metastasis. The next slide, please. So biopsy of the subpectoral lymph node shows again the same thing: ERPR negative, HER2 2+, FISH negative. Now the PDL1 CPS score is 90%.
Thank you, sir. You only have.
Pardon me? Hello? Almanu?
Hello. 5 minutes to conclude, sir. We are running short of time. Hello.
Sure. So you can skip the case if you want to, buddy. The control
No
is in your
problem,
hand.
sir. Okay.
Sure. Skip the case, we can come to the summary, and I think that would help you answer. So, so what we wanted to point out essentially is that there was a lacunae. That 50% of the metastatic breast cancer that we see are HER2 low or HER2 positive. 50% of the patients that we see. That in the third line, these patients are doing dismally bad. So we are seeing a median PFS of 4 months, 6 months, 7 months in our patients. That 50%, as I mentioned, are HER2 2+, 1+, and there is almost a tripling of overall response rate and almost a doubling of PFSs in these patients with addition of NHER2. And therefore, we feel that it is high time that we offer all these patients NHER2 as standard of care. Once, for hormone receptor positive patients, they have failed on their endocrine options. On triple negative patients who have failed the first lines of chemotherapy. The next slide, the thank you slide, buddy. Thank you.
Thank you, Dr. Akash. It was really good to hear you as always. A very knowledgeable thing, because most of the time we think we are well versed with the drug, and I feel you agree. But it's good to hear even single things we are supposed to take care. The thing is, just a small question: if the patient is triple negative, say HER2 very low or ultra low, so have you started using such things in some patients who are HER2 0, or you think
No, sir.
it is an option which can be considered?
Yeah. So, sir, we use this in HER2 1+ or 2+ FISH negative. That has been our practice and offering. We know that there is data of using this in ultra low, ultra low, and as we go down that road, but we haven't offered our patients yet, and neither have you. So we stick to this guideline of HER2 low only.
Okay, no HER2 0.
No HER2 0 in our practice now.
You feel can be offered to someone who is HER2 0 and it's going to work? Because most of the time the patient has progressed on many of the lines. So will it be option in the future?
So sir, we know that it is a valid option for these patients off label, of course, but it is a valid option once we have exhausted everything. But how we are practicing currently, are we are sticking to this HER2 1+ or 2+ with FISH negative in HER2 low positive patients. That's how we are practicing.
Thank you, Dr. Akash. May I now invite Dr. Praveen Paliwal? Dr. Praveen Paliwal is a medical oncologist and head at Medical Oncology, Bansal Hospital, Bhopal. And he's going to have a word on response-driven management of HER2 positive early breast cancer. Thank you, Dr. Praveen. Please proceed.
Yeah, thank you for the invitation, sir. I thank Rakesh sir and the Zydus for giving this opportunity. So my slide is visible. Hello?
It's visible and you are audible.
Yeah, thank you. So the last topic for for tonight. So the response-driven management of the HER2 positive early breast cancer, and I'm going to focus more on the data of the TD1, that is the Catherine 1, basically. So we know that the in the at the end of 20th century, the HER2 was discovered, and we know that the biology of disease was very bad. So these patients were not doing well compared to the ER positive. So, and when we have the molecular data like the luminal A, luminal B, basal HER2, the patient. So compared to the patient luminal A, luminal B, so the HER2 have a very dismal outcome. And at a time we don't have the drug like the trastuzumab at a time also. So as of now in the 2024, we know that the disease is as bad as the drug is available. So we know that if we have very effective drug like we heard in the last talk by Dr. Akash, TDXT, so that has changed the landscape. So we can make a bad disease into a good disease by a good drug also. So the journey started from the trastuzumab. In the 1999, we have the trastuzumab first come in the metastatic setting, then come the early stage breast cancer. Now the plethora of drugs are available to target that HER2. So the pertuzumab, the then came the lepatinib, tucatinib, the TDM1 came, TDXT, and then we have the margetuximab also. So now, these are all the drug we use in some setting, either the early breast cancer and the metastatic setting. So but how far we have achieved from the addition of the trastuzumab. So the early use was, as I mentioned, in the stage 4 metastatic breast cancer. So then later on, based on the first trial, the HERA trial tested the use of trastuzumab in the HR positive breast cancer. Then came the NSBP 31 trial, then the B surgery 00 study that compared the adramycin versus the adramycin free regimen. So basically, from this adjuvant setting of trastuzumab, what we have seen in our course of we have a good mature follow-up of 10 year, 15 year. So we get a disease-free survival benefit around to the tune of 7 to 10% with the addition of trastuzumab. Also the OS is also significant to the tune of 6 to 10% with the benefit of the trastuzumab. More benefit in the stage 3, less in the stage 2, but still all this group were benefiting from the addition of trastuzumab. So trastuzumab improved the DFS and the OS in this group of patients. So but still we know that the still so many patients they recur, and they recur in the form of stage 4 cancer only. So how we can minimize the risk of recurrence, either local recurrence or the distance recurrence in the HER2 positive early breast cancer? So first we have to define which are the group of patients who are the at high risk, so that we can target that group of population. So as we can see this slide, so there are basically two group of patients we can define, so that they are at the high risk of recurrence. One is the patient who has received the neoadjuvant chemotherapy, that is the usual standard of care for most of the HER2 positive breast cancer, who have the after the completion of neoadjuvant chemotherapy radiation surgery. We found that there is some kind of residual disease, that means they don't get the PCR, so they are at high risk of recurrence compared to the patient who got the PCR. Or if the surgery has been done upfront, so and at the time of pathology report we found that there are multiple not positive, or the T3 or T4 disease there. So we know that this group of patients they are at high risk of recurrence. So how we can manage, how can decrease the risk of recurrence in this group of patients who are at the high risk of the recurrence? So we know that the neoadjuvant chemotherapy can be prognostic and predictive. Prognostic in the terms, the patient who got the PCR, they do well compared to the patient who has residual disease. And we know that it can help also to change the treatment, that it can be predictive also. If we change the treatment who are at not got the PCR, so the risk of recurrence is minimized. So and sometimes third, in vivo we can address the efficacy of the drug, but mainly clinical point of view, prognostication and predictive, if we can change the treatment. So we know that in breast, at least we know have the mature data for the HER2 positive and the triple negative. So patient who got the PCR after the completion of the neoadjuvant chemotherapy, they do well compared to the patient group of patients who are non PCR. So they are all this study they have tested the neoadjuvant strategy in the breast cancer, the Techno trial, Japar, Kanu trial, New Alto, that include the trastuzumab plus lepatinib, NHB 41, Neosphere, that include the trastuzumab plus pertuzumab. But we can see from this all the clinical trial, the randomized control trial, the patient who got the PCR, they are doing well to the tune of 10 to 15% better. The patient who does not get the PCR. So basically, so we know that the PCR help the with the patient who got the PCR, they do well, and then we can change the treatment also. So who are the patient who are suitable for the neoadjuvant therapy? So classical teacher is inoperable breast cancer, like the inflammatory breast cancer T4D, the bulky or the matted node 9 to XD node, they should receive neoadjuvant chemotherapy. N3 nodal disease, T4 or T3 tumor, they should get the, because we know that they are inoperable, or at the time of surgery they may need some kind of plastic surgery for the some kind of graft or flap, so they need the neoadjuvant chemotherapy to decrease the size of the primary or the node. Or the operable breast cancer, but we want to check the patient who will get the PCR, not PCR, so that we can change our treatment based upon the that information. So like for the HER2 positive disease, if the tumor is more than 2 or centimeter or not positive, they should get the neoadjuvant chemotherapy. Or some selected TNBC like the more than T1C, they should also get the triple negative breast cancer. Sometimes the surgery is possible, like the large primary tumor, but the lady desire for the BCS, then the neoadjuvant can be offered to decrease the size of the tumor. Or the clinically not positive disease, but to make them not negative, so that we can maybe sometime we can avoid the surgery. So for that, in the setting, the neoadjuvant therapy should be offered to the patient. So we as we discussed in the Dr. Sonak slide also, the talk also, and in the previous talk also, slide also, the patient who does not get the PCR, so they don't do well compared to the patient who got the PCR, as we can see in this slide. So patient who got the PCR, the event free survival is around 86%, but the residual disease is 63, around 70% difference, with the hazard ratio of 0.31. And the same is true with the OS data also. So patient who got the PCR, 95% of OS survival for the PCR. Patient who got the PCR, compared to the around 75% difference of 20% in the patient who does not get the PCR and got the PCR. So for the patient who got the PCR, they're doing well, so we just have to continue the same treatment that we are given, like the trastuzumab for the HER2 positive. But the patient who got not the CR, they need some kind of treatment that we haven't done so far. That means they need the escalation of the adjuvant therapy for the residual disease, to minimize that, or at least to decrease that gap of around 15-20%. So based on that setting, so in the adjuvant setting, so patients who are at high risk of the recurrence, or who has done the either they got the PCR or they received the neoadjuvant therapy, or their upfront surgery has been done. So there are 3 drugs that can be used at some point of time. So depending upon the patient has done the surgery upfront, or received the neoadjuvant chemotherapy. So TDM1 get the approval in May 2019 based on the patient who received the neoadjuvant chemotherapy and residual disease is there. Trastuzumab and pertuzumab based on the affinity trial. So either the patient or surgery has been upfront, but they are at high risk of recurrence, that means not positive disease, or it used in combination with neoadjuvant chemotherapy has been was used, then we can still continue the same trastuzumab pertuzumab in the adjuvant setting. Niraparib can be used in that group of patients who need the extended adjuvant treatment for the patient with HER2 express and the ERPR positive patient after completion of the trastuzumab based therapy. So these 3 drugs that can be used in adjuvant setting after the completion of adjuvant therapy. Neratinib is the cost is high, there is no generic available, and drug is not has been so far launched in India. Pertuzumab, the original was high cost, but now with the biosimilar is available, and the same with TDM1, now the biosimilar is available, so that we can use in the setting that where we can to minimize the risk of recurrence. But India still, the pertuzumab and TD1, either the original or the biosimilar, is out of reach of the most of the patients. So most of the high risk patients still get the trastuzumab as adjuvant therapy only. So the uh, the the role of TD1 come basically from the Catherine study. So the study design was very simple. So patient who received the neoadjuvant chemotherapy, minimum 6 cycle of chemotherapy, and in addition to chemotherapy, minimum 9 weeks of trastuzumab was used. Second, HER2 target 3 was allowed at this, after the start of the trial. The primary objective was the patient who received the who has residual invasive therapy in the breast or auxiliary node, or they were stratified. Randomization was done within 12 weeks of surgery. So the TDA1, the Joseph standard dose of 3.6 milligram per kg every 3 weeks for 14 cycle, or was the trastuzumab alone was to be continued at 6 mg per kg every 3 weeks for 40 cycle. Around 1,500 patients, good number of patients were included in this trial. The primary endpoint was IDFS, and the secondary endpoint was the OS data and the secondary endpoint. So the primary results were published in 2019. So the invasive disease-free survival 3 year was benefiting, the patient was benefiting from the addition of the TD1, 88.3 versus the 77, a gain of 6%, around 11% with a hazard ratio of 0.5. That means around 50% reduction in the risk of disease progression with the addition of TD1. The patient who has residual disease after the completion of chemotherapy, neoadjuvant chemotherapy. The OS data was not the mature at the in the 2019, but long-term follow-up was there for the in 2023 was published. So the IDF benefit was maintained. So gain of around 13%, 80 versus 67 at the 7-year follow-up. And we have the OS benefit mature data also there. Updated OS data benefit with the Catherine data around 5% benefit with the addition of TDM1 compared to the trastuzumab at the end of follow-up of 7 year as a ratio of 0.66. So basically all the subgroup, either they were ERPR positive, negative, trastuzumab alone or trastuzumab plus, they receive additional HER2, mainly the pertuzumab, they get benefit, not positive, not negative. So they usually we say that the patient not negative and they have residual tumor, so not to offer maybe the TDM1, but still those group of patients also, if they have the residual disease, that means that indicate the bad biology, they benefit from the addition of the TDM1. The surprise is there that only the around 300 patients they receive the anti-HER2 treatment in the neoadjuvant setting. Maybe the pertuzumab was not popular or approved at that time. Most of the patients they receive the trastuzumab alone group, and in the subgroup analysis, sometimes the residual tumor is there, kind of a 4 mm, 5 mm, or microscopic disease also. But as we can say, the subgroup analysis, so most of the patients, around 637 patients, they have the YPT1A, that is 5 mm, T1B 5 to 10 mm, or T1 microscopic. They still get benefit if they have residual tumor with the addition of TD1. We can say the hazard ratio of 0.65 in the absolute term. In the IDFS 78 versus the the 74 versus the 82. So that means in that group also, where the disease is residual tumor is kind of millimeter only. So we should discuss that although you have get a good response, the tumor is millimeter residual only, but if you change the treatment from trastuzumab to the TDM1, they will get in benefit in terms of the IDFS. Same is true for the node also. If the tumor is like the N1, though around 400 patients, so the IDFS 63 versus the 78. So basically the disease microscopic or macroscopic, so they are getting benefit from the addition of the TDM1. As mentioning the speaker, publishing this in the talk. So the patient who received the newly diagnosed HER2 positive breast cancer, if they receive the neoadjuvant chemotherapy, surgery has been done. If the PCR to continue the trastuzumab or pertuzumab in combination, but there is no residual disease, there is a strong case of from change to trastuzumab to the TDM1. So the affinity trial, so basically the that affinity trial tested the use of the pertuzumab in the adjuvant setting only. The patient who has done surgery upfront has been done. So patient with HER2 positive early breast cancer, no prior chemotherapy has been done. So not positive any tumor size, or more than 1 centimeter tumor, no negative, they were randomized to the chemotherapy or the chemotherapy plus the pertuzumab. With a 10-year follow-up, we can see the node negative patient, the benefit was hardly anything, but for the node positive disease, so for the 4-year IDFS 3.2 versus the 4. At the 6-year 4.3, and the 8-year IDFS is done on 5% to the tune of 5% only. For the ERPR positive 2.8, and for the ERPR negative 2.3. So basically that is not irrespective of the node positive disease. So basically, patient, the proposed study for the early breast cancer, if the surgery chemotherapy is planned based on the tumor size, not positive disease, So PCR to continue trastuzumab. If the node was positive in the at the earlier image and the imaging study, so to add the to continue pertuzumab. Non-PCR strongly recommend to use the TDM for 14 cycle. So if the upfront surgery has been done, the early stage like PT1 up to 2 centimeter, we can use the AP trial, so AP strategy. So weekly 12 paclitaxel plus 1 year trastuzumab. But if the tumor is like the NEPT or not positive, to use the chemotherapy, either TCH or TCPH. When not positive, to use the pertuzumab in combination with the chemotherapy. To summarize my talk, so patient with HER2 positive breast cancer, the availability of the HER2 targeted agent have markedly and rapidly improved the overall outcome. Need to offer the neoadjuvant treatment for most of the HER2 positive patients to adopt a response based treatment modification. For the adjuvant study, Catherine, based on the Catherine, to use the trastuzumab based on the Catherine trial, and the based on the Afrin trial for the not positive disease, to consider the use of trastuzumab pertuzumab in combination with chemotherapy. Uh, uh, Thank you so much for the patient listening.
Thank you, Dr. Praveen, for throwing the light on how to manage HER2 positive things and what are the standard or universal guidelines we are supposed to follow. I am thankful for all the faculties who have taken active participation. The presentations were really very good, and I am thankful to all the sponsors. Thankful to Tarun Bhai, but still the conclave is still on. So we are supposed to meet again on 15th November at sharp 7, so that we conclude tomorrow with other some brainstorming topics and upcomings in oncology. Thank you all.
Thank you so much, sir. Technical support, kindly close the meeting.